Thank you guys for having me. So I'm going to talk about the benefits of CBD, which is called cannabidiol, and medical cannabis. So cannabis has been used for over 4,000 years in many, many countries, many cultures, for all different conditions. So it's not something that is exactly new. However, because of a lot of issues with the law, it's very difficult to actually use it in the United States. So there's been many uses, for example, for arthritis, for seizures, for pain, for many different conditions. And then in 1937, the Marijuana Tax Act made it illegal in the United States. And so in 1970, there was the Controlled Substance Act, and that basically made it a Schedule I drug, which says that there's not enough medicinal benefits and there's not enough evidence, and it has a high potential for abuse. So Schedule I drug we know is like heroin, LSD, and obviously it's very difficult to do good human clinical trials on a Schedule I drug. So because of this, the stigma has really caused a lot of issues in the way that we view cannabis as medicine as opposed to as a recreational drug. So cannabis is composed of over 100 cannabinoids. These are all different substances in the plant, and there's actually over 400 compounds in the plant. And so they've been able to isolate all these different cannabinoids. The two that are the most prominent and the most studied are CBD and THC. And so they found CBD, or cannabidiol, in 1940, and then Raphael Mechoulam in Israel discovered THC, which is one of the psychoactive cannabinoids in cannabis. And so even though we talk a lot about CBD and THC, there's many other cannabinoids that are used for different medicinal benefits that are just not available right now in Florida in a significant amount, but other countries, West Coast, they can have, let's say, CBN for sleep, or different types of cannabinoids isolated that can be used, not just THC and CBD. So they discovered CBD and THC in cannabis, and then they discovered that humans have cannabinoid receptors. So we all have a CB1 and 2 receptor. The CB1 is mainly in the central nervous system, and therefore it controls things like appetite, nausea and vomiting, cognition, pain, thermoregulation, reward, intraocular pressure, versus CB2 is mainly in the periphery, dealing with immune function, pain, and inflammation. So they discovered we have these receptors, and then they discovered that we actually make our own marijuana-like molecules that they called endogenous cannabinoids. And so they named one of them anandamide, and ananda really means bliss, so it's really the bliss molecule. So they discovered we all make endogenous cannabinoids, we have receptors in our body, and they called this complex signaling pathway the endocannabinoid system. And so we all have an endocannabinoid system that's basically all based around cannabis-like molecules. And the main purpose is to maintain homeostasis. So for us to eat, sleep, relax, forget, and protect, we use this endocannabinoid system. And that's why we can treat so many conditions with cannabis. So since you guys are all physicians, this really helps you understand how the system works. So the endocannabinoids are made on demand and released from postsynaptic neurons. So here you have, on the bottom in red, you have the endocannabinoids, and so they're released from the postsynaptic neurons. They travel retrograde across the synaptic cleft, bind to the CB receptor, and they're basically there to suppress the neurotransmitter, whether it's inhibitory or excitatory. So too much of something, too little of something, it's basically telling your body how to keep this neurotransmitter in homeostasis is the most elementary way of looking at the endocannabinoid system. And so it's more than just interacting with the CB receptors, but there's also TRPV1, GP55, many other pathways and many other receptors that cannabis and endocannabinoids actually bind to. So for example, here you see how calcium on your left, so the calcium influx into the postsynaptic cell stimulates the release of an endogenous cannabinoid. And you see the 2-AG, or one of the endogenous cannabinoids, will go retrograde to the presynaptic CB receptor, which will then close the synaptic calcium channel, stop the release, and this is how it maintains homeostasis. So if someone's having a seizure, for example, or having acute pain, it's basically working on that specific neurotransmitter, which we all know a lot about. So it's also important to differentiate between THC and CBD when you're talking about medicine. So this is very important to leave understanding the difference between the two and when you would use one versus the other, or when you would use a combination of the two. So unlike THC, CBD doesn't bind directly to the receptors. So it actually suppresses the FAAH enzyme. And so it doesn't work directly on the receptor, but it modulates the endocannabinoid system. And so that enzyme is responsible for breaking down anandamide, or our endogenous cannabinoid. And we all want our endogenous cannabinoids to basically stay around for as long as they possibly can. As we age, we have less and less endogenous cannabinoids, and that is a hypothesis that could possibly cause symptoms that we have when we're younger to turn into chronic diseases. So anandamide is a cannabinoid that occurs naturally in our body, and we want this to stay around for as long as we possibly can, and even using cannabis can actually stimulate us to produce more of our endogenous cannabinoids and also increase the CB receptor density. So the other benefit of CBD is that it can actually inhibit THC from binding to the receptor and therefore minimize the psychoactivity. So when you need to use THC in a patient, you can also use CBD with it just to take away that high or psychoactivity. So differentiating between the two, like I said, CBD doesn't bind directly to the receptor. It inhibits the enzyme, and it weakens the ability of THC to bind. So it's great as an anti-inflammatory. It's good for anxiety, as pain medication, as well as an antioxidant. And then THC, that's better for, let's say, more central nervous system things like nausea and vomiting, increasing appetite, pain, spasticity, as well as sleep. So this really represents the human endocannabinoid system. You see how THC will bind directly to the CB1 receptor, but CBD doesn't bind to any of them. It just modulates the system. You see in light blue that the receptors of CB1 are mainly in the central nervous system, versus CB2 is in the abdomen or the periphery. And then on the left, you also see in green what you call trichomes. So trichomes are the very end of the cannabis plant where all of the cannabinoids are found. So CBD, they call it a whole system stabilizer because it has so many roles and it has so much potential because of the amount of receptors that it actually activates. So we use it for addiction, for sleep, for nausea and vomiting because of the role with 5-HT1 or the serotonin receptor. It binds to TRPV1, which we use for pain, GPR55, which has been shown in cancer cell proliferation, as well as bone density. And there's many other receptors that CBD will bind to. It can have neuroprotective effects, and we use that for seizures, dementia, adenosine reuptake. In some countries, they actually use it to increase blood flow, even in the emergency room when someone's having a stroke or an MI. And mainly, it's just a great anti-inflammatory. So when we think about inflammation, sometimes we think about osteoarthritis. However, when we think about inflammation, we should really think of the whole body in terms of the GI tract, the brain, all these potentials that it can be used for as an anti-inflammatory. So there was an interesting study done where they looked at anandamide levels. So they looked at our endogenous cannabinoid levels, and they had controls versus people who had just gone for a run or cycled. And they found that afterwards, after exercise, the anandamide levels rose. And so they basically assume that the runner's high is related to the fact that our endogenous cannabinoid levels increase. And so we have a lot of different possibilities as to why after exercise we would have that feeling, but the runner's high may be attributed to an increase in our endogenous cannabinoid levels. So it's important to understand this the 396-page report that came out by the National Academy of Sciences, Engineering, and Medicine. So this came out in 2017, and what they did was they looked at 10,000 research studies on marijuana, and they came up with 100 different conclusions. And it was basically just looking at, do we have enough evidence to say something is conclusive or substantial, or do we need more evidence about a specific condition or a side effect? And so they discovered that there's conclusive or substantial evidence that marijuana is effective for the treatment of chronic pain, nausea and vomiting in cancer, and the treatment of spasticity in MS. So those are the three conclusions. They discovered that smoking marijuana is not associated with lung, head, or neck cancer, which is important because a lot of patients are hesitant to smoke or even vape cannabis. There's moderate to limited evidence that marijuana is therapeutic for insomnia, increasing appetite, decreasing anxiety, and combating the effects of PTSD. There is substantial evidence that regular marijuana smokers are more likely to experience chronic bronchitis. There's evidence suggesting a link between prenatal cannabis exposure and lower birth weight, and substantial evidence showing an increased risk of developing schizophrenia. So, you know, it's important to think, okay, what are the contraindications? Who wouldn't you use cannabis on, or who wouldn't you recommend it for? And so saying that there's increased risk for schizophrenia is really not clear, because perhaps someone is self-medicating, or perhaps they actually, so it's hard to say whether it's a correlation or causation. Are they using cannabis because they're self-medicating, or are you actually saying that that this is attributing to your schizophrenia, which doesn't seem likely to me. Usually, obviously, if someone's having like an acute psychotic event, that's the time we wouldn't use something like THC, which is psychoactive. So, I guess in the mental health space, it's very controversial, especially in the addiction space, which I'm going to talk a little bit about. So the entourage effect is important, and it basically just means that all the cannabinoids working in synergy together will have more of a beneficial effect than one isolated cannabinoid. So when people just use CBD, just the isolate of CBD, they're not going to get as good of an effect, for example, as if they had a full spectrum CBD, which means it has other cannabinoids in it as well. And so there's been different studies looking at combination of CBD and THC for different conditions, like, for example, for pain, for cancer. And then there's something called terpenes, which is another part of the plant. And terpenes is what makes the plant smell. It's what gives it its aroma. And so the terpenes actually are in a lot of the foods that we eat, and they also have medicinal benefits. And so, and terpenes really guide how the patient will feel. So when we talk about strains or cultivars of marijuana, it's really a patient preference, and it's not that strain or that name of that strain will actually give you a certain effect because it's a, let's say, indica versus sativa plant. It's actually the terpene in the cannabis that's driving that. So if you wanted to sleep or if you wanted to relax, it's actually the terpene and not exactly the strain. So, for example, limonene is in citrus fruits, and it can actually be used as for anxiety, as opposed to, let's say, myrcene is very effective for sleep. So a strain or cultivar that's high in myrcene may actually cause sleep, not just the fact that it's in indica, for example. So we've all heard of CBD hemp oil. A lot of our patients probably use CBD, buy it from, online, or there's many places that you can purchase it, and it is legal in all 50 states. A lot of people are trying it without really talking to their physician, which is okay because a lot of physicians don't know anything about it. So there's a difference between hemp and marijuana, and hemp is really the stalks. That part is actually, they take the CBD from that area and they make that into a CBD oil. But hemp is really just a legal definition. That means it has to have less than 0.3% THC. And so a lot of people are using CBD oil, and maybe it's helping them, maybe it's not, and we all also know about the placebo effect, but some hemp oil is better than others, and some are not even tested. So there's labs that you can send the oil to, and they give you a full cannabinoid profile. They check for pesticides, mold, lead, anything that can be taken up from the soil, basically. So The extraction method is very important, and the fact that it's a full spectrum is very important. Currently in Florida, we can register a patient, meaning they can use what we call the MMTCs, the Medical Marijuana Treatment Centers, which really means dispensaries, if they have one of these 10 diagnoses. So HIV, AIDS, Parkinson's, MS, ALS, epilepsy, cancer, PTSD, Crohn's, or glaucoma. So those are the 10 qualifying conditions that they've come up with in Florida. And then there's another part that basically says, or you can have any chronic debilitating like condition of one of the 10. So for example, if you had anxiety, you can justify that anxiety is similar to PTSD, or if you had ulcerative colitis, you can justify that similar to Crohn's disease, and then you're able to register the patient with 1 or 2 extra steps of just kind of justifying that to the Board of Medicine and Department of Health, and stating in the literature if there's actually any evidence for that specific condition. So we have a little bit of leeway in Florida. However, some try to stick to the 10, but for us, or for me especially, most of my patients have chronic pain. And so chronic pain isn't a qualifying condition. And sometimes you have to be a little creative, and you just have to justify why it's a debilitating condition. And so it's interesting because they use those 10, and then they included, or you could have chronic non-malignant pain related to those 10, but you still have to have those 10. So we're hoping that as more people are registered with certain conditions and they see that these continuously come up on the registry, that they'll add to the list of 10. In terms of being a qualifying physician, you have to take a 2-hour CME course that's mainly about the law and not that much about any medical benefits of cannabis. There's 13 licensed dispensaries right now. There's 4 that are pending. They said once there's more than 100,000 patients on the registry, and we have over 140,000 patients on the registry, that they were going to open up to more licenses. So people will be getting more licenses for dispensaries. And this shows how there's about 9 that are what they call adult use, is the other term for recreational. So there's 9 states that have adult use marijuana versus 30 that have it for medical marijuana. This is an example of what a dispensary looks like. So when the patient actually gets their card, this is one of the dispensaries in Florida. They are able to go in, there's a guard, they check your card, your registry ID number, and then you can purchase things based off of what the physician recommends. So you have multiple routes of administration, and they used to only allow you to have 2 routes of administration, whether it's oral or inhalation or topical. Now you can actually have multiple routes, more than 2, and we give the patient a specific amount of milligrams per day. And then they're allowed to, that order expires after 70 days with up to 2 refills, so that they're okay for about 6 months. This is an example of some of the products. So you see what a vape pen looks like. So it's basically oil in an inhalation route on the top left there. There's transdermal patches that supposedly have systemic effect. There's oil that you can use sublingual or capsules, topical creams or sprays that you can use orally as well. So different routes of administration. So cannabinoids are hydrophobic. They're insoluble in water, so they like fat. Someone who perhaps has a higher BMI may be able to tolerate a higher milligrams of cannabis. And so smoking isn't legal in Florida. So you don't get whole flower when you go to the dispensary. You get it in the form of oil. And so vaping is the safest inhalation route. It's the fastest speed of onset. If someone's having acute pain or a panic attack or something they need to treat acutely, vaping is the best way to do that. And it's a subcombustible temperature, so you're not allowing carcinogens into the lungs. The problem with vaping is that the pens are it's not the most sophisticated technology right now. So vaping's one option. Then there's sublingual, where you can use the oil under the tongue, and even the sublingual route is kind of controversial because we do absorb things in our mouth. However, most of what we're using is not going to be absorbed sublingually. So if it's an oil base, it's not really absorbed. So people actually end up getting effects from sublingual dose much later as they digest it. Edibles will take a longer time to actually take effect, but they'll also have a longer duration. So someone who can't stay asleep, an edible route is a great option because they'll be able to take it, let's say, an hour before bed, and it'll last them a good 8 to 10 hours. Also, once you are using an edible form in the liver, there's a conversion from 9 to 11 hydroxy-THC, which is actually much more potent. And so people who use edibles will have to be careful because there could be a higher psychoactivity from using any type of oil in food, basically. The capsules are similar to edibles, also longer acting. And then topicals, it really depends what the topicals are used with to see how deep they'll actually penetrate. So cannabis is a different type of medicine than we're used to, let's say, recommending or prescribing. It's something that is really self-titrated, which is the biggest problem. I sometimes relate it to something like gabapentin, how we start off low and then increase it over time. It really depends. Someone may be affected. Someone may use THC, have no psychoactivity, and someone may use 1 milligram and be completely high. So everybody's endocannabinoid system is different, and therefore it's really a self-titrated start low and go slow and see how the patient's able to react to it. So it's important to be consistent before you make any changes. You don't just start at one dose and the next day continuously elevate it. And there's a biphasic curve where as you're increasing the dose, you'll continuously get more benefit. However, once you get to a certain peak, more doesn't always mean that it's better. So as you continuously take it and you're at a good level, it doesn't mean if you take more, you're going to get more relief. You could actually have more psychoactivity or worsening symptoms due to taking more than what you would need. And then again, I talked about different cultivars like sativa versus indica. Supposedly, sativa will make you more alert, give you more energy, versus indica is better for sedation and anxiety. So there's many medical benefits, and I'm going to talk about the ones that we would commonly see and give some good case presentations. So let's talk about a 55-year-old woman on Lexapro, Xanax. She's very healthy. She does mindfulness and Pilates, plant-based diet. So this is very common, and even as a pain doctor, I see this type of presentation all the time where they just basically want to get off their antidepressant or their benzo. And it's a very easy transition because something just like CBD would be effective. They wouldn't even have to use any psychoactive cannabinoid. They wouldn't need THC. And basically you're substituting one for the other. So there's this huge substitution effect of the amount of pharmaceuticals that we're able to decrease by using even CBD. It just depends whether you need it long-acting or short-acting. So acute stress can cause a reduction in our anandamide levels, and so using CBD will actually help to normalize this, and we use it a lot for social anxiety and even PTSD. Similar to for depression, CBD can increase serotonin, THC will block GABA, can increase dopamine. And so there's a very important concept about forgetting, and the ability that we're able to forget is actually protective. We all think about memory and needing to remember as much as possible, but it's also effective for people like with PTSD who need to forget certain things or having continuous nightmares or traumatic memories. It's very protective for them. Insomnia is one that is, most of the patients that I treat for pain, they'll come back and they'll say, maybe my pain decreased, but I definitely know I'm sleeping better. So insomnia is one of the easiest ones to treat with CBD. And this would just depend whether the person has issues falling asleep versus staying asleep. So if you're not able to fall asleep, you want something short-acting like an inhalation route or a tincture perhaps, or you can dose it so that they take 1 hour before bed, they put the oil in food, and then it becomes a longer acting. Also, we use it for ADHD. So in lower amounts, it can actually cause people to feel more awake and give them more energy, and higher amounts will cause sedation. So we know a lot about opioids. We know that the United States consumes 80% of the world's opioids, that 150 Americans die from opioid overdose, and 68,000 in 2017. $72 billion spent on medical costs for opioid abuse. And so most of the times it's the physician who starts a patient on an opioid, and that's why July 1st there's so many changes going on now with the opioid guidelines, especially for acute pain, so that we're not allowing our patients to become physiologically dependent on opioids. They found that there was 2.2 million less opioid prescriptions written once medical marijuana became legal in 2018, and a 15% reduction. So it really is a good substitute for opioids and an option, for this opioid epidemic. So as you see here in green on the left, after 2 years of legalizing cannabis in a state, there's a 25% reduction in opioid fatalities. And then we can talk about the drugs that are deadlier than marijuana. There's no potential for overdose. There's no toxicity with marijuana. Nobody's ever died from the use of marijuana, as opposed to over-the-counter medication, alcohol, tobacco that we're all aware of. So there's been 2 similar studies, and I'm doing a study now with FIU that's a very similar one. There was one at Hebrew University and one at University of Michigan, and so they basically looked at their clinic, and they looked at 176 versus 185 chronic pain patients who had tried and failed injections, physical therapy, medication, and they found that when they started using cannabis, there was a 66% improvement in their pain symptoms and quality of life, and a 44% reduction in opioids. And there's a Dr. Sulak in Maine, and he's found that there's like even a 80% reduction. He's able to get a lot of his patients off opioids and also improve quality of life. So there's many mechanisms for why cannabis can be used as an analgesic, and there's many reasons why we would consider this over opioids, obviously. And then I'm going to talk a little bit about the endocannabinoid deficiency syndrome. So a few quick examples. So a 65-year-old with neck pain, low back pain, and renal insufficiency. This is someone that we can think about perhaps just using CBD topically or sublingual. And usually what I do is I try to see how much benefit they can get from just CBD before I would even need to register them or have them use THC, because maybe we can actually not even enter that part where maybe they would have the psychoactivity and maybe they would benefit just from CBD. So for example, a 75-year-old with knee osteoarthritis, peripheral neuropathy, and insomnia. So she was just taking CBD when she came to me, and a lot of times I'll say, well, how do you feel about medical marijuana? And most people say, okay, I'm a child of the 60s, I'm okay with it. And there's this age range that I find they're really willing to, as opposed to, let's say, and most of my patients I would say are 60 and up. So they're actually willing to do it, and they're not nervous about it, as opposed to, let's say, more of like the 40-year-old, 50-year-old, because they're really involved with the stigma. And the difference is that in the 60s, the THC content used to be about 4%. Now it's 20, 25, 30%. So it's definitely a different type of cannabis, and that's why we always start very low. So this type of patient who was using CBD, I always start a combination of the two. So there's different ratios of how you can mix the CBD and THC. So they have, let's say, a 1-to-1, a 1-to-4, a 5-to-1, meaning how much CBD do you need to offset any psychoactivity from the THC. So for pain, and especially neuropathic pain, the 1-to-1 combination, which means 50% of each, is often used. And it's used, but starting very slow and starting very low, because you can always add CBD if they do have a psychoactive effect. So for example, for this patient, she can use 5 milligrams sublingual of the 1-to-1 2-3 times a day, and then maybe at night she can use more of an indica strain that will help her to sleep better. Or if you have someone like, for example, this woman who was on fentanyl and Percocet, we would obviously need a longer acting form of cannabis to offset the fact that she's been on fentanyl, right? So this woman was actually a fibromyalgia patient, and she was on 100 micrograms of fentanyl and 4 Percocets a day, and trazodone, tizanidine, Ambien, melatonin, naproxen. I mean, kind of typical to what we see, but her diagnosis was fibromyalgia. And so what I did was, and I normally just take their short-acting pain med and see, using that one-to-one combination, how many milligrams they need to not take a Percocet. And so it's very simple, because they're able to do a little trial and error, starting very low, and figure out, okay, 5 milligrams, and and then I don't need my Percocet, and then we wean them off the short-acting, and then I add a longer-acting, like a capsule, for example, to try to start weaning them off the longer-acting opioid or fentanyl in this situation. Or she can vape as needed instead of using the Percocet. So it's really substituting short versus long. And then same thing for sleep, we can add more of an indica versus during the day a sativa or a hybrid. So the endocannabinoid deficiency syndrome is very important, because we don't know what causes things like migraines, fibromyalgia, chronic fatigue, IBS, and so there's been research done showing that people who don't make enough of their endogenous cannabinoids will actually have symptoms like chronic fatigue and chronic pain, and even perhaps migraines. And also, as I have a lot of these patients, I see that when you actually give them CBD or cannabis, they're able to get off all the meds that really aren't working anyway, and improve quality of life, sleep much better, and have less pain. So this syndrome, I think, will get more and more attention as the patients are able to get off medication and feel better. But there's also a lot of science behind it. So they've done spinal taps. They've actually measured endogenous cannabinoid levels. You can measure it in plasma and see what your endogenous cannabinoid levels are, so that you're able to supplement with cannabis and then, let's say, have it rise over time. The problem is when you do it in blood, it breaks down very quickly. So in the United States, not that many people are going to allow you to do a spinal tap to measure their endogenous cannabinoid levels. This was a study done looking at the efficacy of medication in fibromyalgia. So looking at Cymbalta, Savella, and Lyrica versus cannabis, and you see cannabis is more than 60% very effective for treating fibromyalgia, versus all the 3 other FDA-approved medications show less than 10%. With migraine headaches, I'll oftentimes use CBD almost like a Topamax, kind of like a prophylactic. So CBD once or twice a day, and then if they do get a migraine, more of a one-to-one in the form of a vape or a shorter acting to try to abort the migraine. And many mechanisms why THC inhibits serotonin. It's also a great anti-inflammatory. So seniors are using cannabis more and more, and that's because they are really the population that has tried and failed everything. There's no risk for overdose, as opposed to, for example, opioids. There's been a 250% increase over the past few years in terms of 65 years and up using cannabis. And also, as they age, their endogenous cannabinoid levels decrease. So I find more and more of my patients are 65 and older and benefiting from cannabis. Also, other neurological conditions like Parkinson's and MS, there's a lot of different studies on Parkinson's looking just specifically at CBD for well-being and quality of life, and then adding in some THC in terms of decreasing tremor, rigidity, dyskinesia. And in terms of MS, there's a medication called Sativex, which is used in many other countries. That's a one-to-one. And so that'll probably come to the United States hopefully soon, which is very effective for spasticity. This is a patient of mine that had cervical dystonia, that obviously we had tried all the different oral medications, Botox, everything, and actually cannabis was the only thing that allowed her to relax and allowed her spasms to allow her to function. In terms of cancer, we also can use cannabis for cancer patients. This was a patient that had fracture. He actually fell, had a compression fracture. We did kyphoplasty, and he was very sensitive to opioids. And so we started him on CBD. It wasn't very effective because he had acute pain. Then eventually he got his medical marijuana card, and we added a little bit of THC, and it was very effective for his pain, and he wasn't at all having any of the psychoactivity because we balanced it out with a 2-to-1 or 3-to-1 ratio of CBD to THC. And later on, he ended up developing cancer, and he was already cannabis tolerant, and so we were able to increase his THC levels to help him with his neuropathic pain. We increased his CBD for anxiety, for appetite, and he actually used it all throughout hospice. And so I actually saw him the day that he passed away, and he was at home, and he used cannabis because he had such good family support, but he used cannabis all throughout his hospice treatment. He didn't try morphine or Ativan or anything else, but to help him with sleep, to help him with pain, anxiety, he used different ratios of CBD and THC in oil form. In terms of cancer, the issue is there's so many different cancers, and obviously there's not enough research right now. And so depending on what type of cancer, for example, breast cancer, there's a study showing how there can actually be an increase in metastasis by using THC if it's an estrogen receptor positive cancer. So it's important to know, obviously, a little bit about the type of cancer, but there's not enough research now. But what they do know is that the cannabinoids can actually block cell growth. They can stop the evolution of new blood vessels to the actual tumor. And the combination is always the best. So doing radiation, chemo with cannabis is always better than doing one versus the other, which is important because a lot of the patients are very hesitant if they're doing chemo or radiation to also do cannabis, to also use cannabis. And I do have patients with dementia that use CBD and even THC, and it took me a little while to start THC, but I realized quickly that it significantly improve their quality of life and improve the caregiver's quality of life as well, because it can really decrease a lot of aggression, help them with sleep, decrease a lot of their agitation, and it is known to be a neuroprotectant. So there's studies showing that the THC can inhibit the enzyme responsible for the aggregation of amyloid plaque. So people are actually using CBD now thinking it's a neuroprotectant and perhaps it could prevent dementia. So when we're talking about cannabis, we also have to think about the concept of addiction, and it seems like there's a 9% chance of addiction using cannabis, and that's just in the literature, that number, which is probably an overinflated number based on people who are caught with cannabis that are asked to go to either a rehab facility because they're addicted to it, or perhaps have another type of punishment. So they choose rehab versus a different type of punishment. It does increase dopamine levels, so it makes people more willing and it makes it more desirable, but it's not a true addiction. It's probably the same as, let's say, coffee. And it actually is used to help with opioid withdrawal. So when people are decreasing their opioids, it's very good for cravings. A lot of the side effects that we know of, the restlessness, the agitation, it can take care of that as well. And so I also do, like similar to opioids, I'll tell the patient to take a cannabis holiday, whether it's one day off a week or 1 week off every 3 months, but because you can build a tolerance to it. So these are all the marijuana-based medicines. So we all know about Marinol. Now Epidiolex was just approved, which is from GW Pharmaceutical, for 2 specific indications for childhood seizures. And that's the first one that's ever a plant-based CBD, which is great because it's not synthetic, and it also means that it's going to be scheduled. And so that means a plant-based cannabinoid medicine is going to be scheduled, which would mean that in the future they would probably have to deschedule or reschedule cannabis to no longer be a Schedule 1 if there's going to be a plant-based CBD pharmaceutical. So it just means there's more research to come, and obviously now the pharmaceutical companies are going to get involved. There are drug interactions, but the same as in any other situation when we would say that, okay, this goes through P450 or 3A4, it's just like everything else. So people are always worried about side effects with cannabis, but they don't even ask you when you prescribe them a medication, well, what about the drug interactions with the 2 medications that your physician gives them? But it's very similar. There's certain things that I look out for, like if they're on certain seizure medications, antipsychotics or anticoagulants. Those are the 3 biggest ones. But there's plenty of people that have been using marijuana for a very long time with their other pharmaceuticals. So the way I look at it is we all need to optimize our endocannabinoid system, and we do that by things like omegas, exercise, decreasing alcohol, eating healthy, and perhaps using CBD. I think that in the future there's going to be a lot more research that is looking specifically at individual cannabinoids as well as receptors, so looking at how to modulate the receptors and also the enzymes in the endocannabinoid system. And now with the pharmaceutical companies, there'll be more plant-based medications approved, but with specific indications. And also, last slide, just to understand that the United States actually has patents on cannabis, so the fact that THCV treats nausea and vomiting. It's an antioxidant and neuroprotectant. It can induce apoptosis, and it has anti-tumoral actions. And it's used in acute and chronic pain as well as inflammation and autoimmune disease. So it's amazing that they actually have these patents, yet it's still a Schedule I drug.